is 8 o'clock, so I figured we can get started at this point. So I'd like to start by welcoming everyone. I'm Mark Albert, and welcome to the August ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we'll be discussing the article, Optimizing Outcomes in Necklift Surgery. So just a couple reminders for everyone. Please mute your microphones. And we'd like to make tonight as interactive as possible. So if you have questions, please enter them in the chat box. Or at the end, we'd love it if you would raise your hand and even turn on your video and feel free to make comments or ask questions. We would absolutely love that. So tonight I'm joined by YAPS committee member, Dr. Deniz Sarhaddi. She'll be fielding your questions and presenting poll questions, which we'll review at the end. So I'd like to begin tonight by introducing our author and our discussants, and then we'll get into the discussion. So tonight we have the honor of having author Dr. Gerry O'Daniel. Dr. O'Daniel is a dual plastic and reconstructive surgeon and facial plastic surgeon in Louisville, Kentucky. He did his plastic surgery training at WashU and head and neck surgery at the University of Louisville. He completed fellowships in craniofacial and pediatric plastic surgery at WashU and in Taiwan, as well as a facial plastic and facial nerve fellowship in Pittsburgh. Dr. O'Daniel also did a research fellowship at the University of Louisville. He's a recent graduate of the Executive MBA program at Northwestern, and he's currently a clinical assistant professor at the University of Louisville. He's a member of the ISAPS Educational Committee as well. Dr. O'Daniel has shared his experience in numerous publications in plastic surgery journals and book chapters. He's been invited to over 90 national and international meetings to lecture, perform live surgery, and perform cadaver demonstrations. So thank you so much, Dr. O'Daniel, for joining us tonight.
Thank you, Mark, for having me.
So our first discussant of the evening is Dr. James Grotting. Dr. Grotting is the immediate past chair of the American Board of Plastic Surgery, past chairman of the Board of Trustees of ASPS, past president of the Aesthetic Society. He's a clinical professor of plastic surgery at the University of Alabama and the University of Wisconsin, and he operates a private practice in Birmingham, Alabama. Dr. Grotting has served as the chair of the Aesthetic Society's Education Commission. He serves on multiple society committees and is a former board member of ASERF. Dr. Grotting has directed a fellowship in aesthetic and breast surgery for the past 25 years, and he's a traveling professor for both the Plastic Surgery Foundation and the Aesthetic Society. He also serves on the editorial board of ASJ. Thank you so much, Dr. Grotting.
Thanks, Mark.
And our second discussing of the evening is Dr. Tim Marten. Dr. Marten is a diplomat of the American Board of Plastic Surgery and founder and director of the Marten Clinic of Plastic Surgery in San Francisco. He completed his plastic surgery residency at the University of Illinois at Chicago and went on to complete 3 fellowships in aesthetic surgery. Dr. Marten is an internationally recognized expert on facial rejuvenation, and he's given over 800 scientific presentations and authored over 30 textbook chapters. He's a member of over 20 professional societies, including ASPS, the American Association of Plastic Surgeons, ISAPS, and the Aesthetic Society. Thank you, Dr. Marten, for joining us. So let's get started at this point. We're going to turn it over to Dr. O'Daniel to share his screen with us and discuss his article.
Thank you, Mark. I really appreciate the opportunity, and I'm very grateful for the recognition that the editorial board has shown for this paper about neck lifting surgery. And I'm humbled to have the discussants of Dr. Grotting and Dr. Marten, 2 giants in contemporary plastic surgery. This is a subject that's very dear and near to our hearts. And so I've tried to objectify neck lift surgery to answer some questions. This paper was put together with the hypothesis that the impact of the soft tissue relationship between the mandible and the soft tissue in the anterior neck create the ideal circumstance or a circumstance that requires operation. So in other words, when the contents fit within the bony confines, we get the ideal angle. However, when we start to see an imbalance, either a smaller mandible or increased contents in the anterior neck, you're going to start to see changes in the cervical mental angle. And then as we age, we have atrophy of the bony structures and we have enlargement of the soft tissue, so that discrepancy in the bony confines and the soft tissue increases. So in other words, we have a fixed container in the musculoskeletal support systems, and then you have the soft tissue that fits in the neck. When it's perfect, we get the 120 or less degree angle. However, when there's an imbalance, we have a volumetric volume push to anterior inferiorly, where you create this obtuse cervical mental angle. So in this paper, what I did was follow 254 patients, pulled 152 patients out that I measured the volume of each subplatysmal and supraplatysmal structure that was taken out. As you can see, the digastric and submandibular gland, as we would expect, are the larger volumes, and then we had much smaller volumes in the other structures. In addition, we look at the frequency, and we can see the frequency of deep fat manipulation is much greater than the seldom performed myohyoid. So it's important to understand that not every procedure is performed on every patient. When we look at the total volume, less than 1/4 of the volume is in the supraplatysmal plane versus 3/4 of the volume in the subplatysmal plane. So what this tells us is that we're dealing with a sculpting procedure that's not extirpative, but requires attention to each one of these structures. So we have reductive maneuvers where we're reducing the fat, muscles, the fascia, and the glands. We also have manipulative maneuvers where we're actually moving muscles and hyoid bone. So what I found is we have mass reduction in some patients where we're taking out large volumes of soft tissue to open up this angle and allow redraping of the skin to create a more pleasing cervical mental angle. In some patients, we're getting minimal reduction, and so we're looking at it as a transition from the submental to submandibular triangle, which requires a minute amount of reduction, but it still requires a reduction. And then we have circumstances where the hyoid is displaced, and we want to lift this hyoid. This requires a manipulative type procedure, such as elevation of the digastrics, to pull it into a more pleasing position. So I've outlined sequence of steps, which first and foremost is wide exposure. This is a basic surgical principle. We then want to examine the deep fat in the submandibular glands. And before we do anything, we want to commit to providing treatment to all of the paramedian volume. In particular, we're talking about the submandibular gland. So what I've done is created an actionable diagram, an algorithm. And this really is an algorithm that helps as an introduction. And as we become more facile, we can move back and forth with the algorithm at different orders. But as we start as a beginning surgeon, this is a good place to look. When you see one thing, you do the next, and understanding every action has a reaction. So what I want to point out in this article is that we're talking about a sculpting procedure, not an extirpative procedure. Every action has a reaction, and we have to follow a very concise pattern, expecting and anticipating the results of the surgery from each maneuver. Thank you.
Thank you very much, Dr. O'Daniel. So next we'll turn it over to Dr. Grotting for his comments.
Jerry, great summary. And as I looked at everybody signing on, I want to welcome the viewing audience. I think particularly those who have stayed up very late at night. There are surgeons from Europe, North Africa, and Asia joining us. So welcome. Jerry, I really think that this is one of the probably most well-written and carefully thought through clinically relevant papers that I've seen in a long time. And it really builds on the early work of so many. I think back to Ralph Millard, of course, Bruce Cannell, Jose Guerrero Santos, Oscar Ramirez, Tim Marten for sure, and more recently, Andre Auerswald, Dozan Sozer. But if you really take the time to study and understand what Jerry has written and review the videos, if you're just starting out, I think it will really give you the confidence to either begin working in the deep neck or improve what you're doing based on the principles that he's set out. And my own evolution into the deep neck occurred largely as a result of a failure to get complete correction in oblique necks when I was trying to do it only from laterally. I went through a phase where I was trying to be minimalist and not open very many necks. But the problem is that you can do that in some patients who don't have that extra submental volume that Jerry describes here. They can be nicely treated with tensioning or divisioning the platysma. and careful removal of the supraplatysmal fat from a lateral approach. But the submandibular gland can be treated from laterally, but it's absolutely impossible to safely reduce the subplatysmal central volume from a lateral approach. So I had several failures trying to do that and had to go back and do secondary deep cervicoplasty to try to correct those. But I want to emphasize some of the things that Jerry's talked about here, particularly the really thorough understanding of the anatomic relationships, because this is an area that we as plastic surgeons really didn't spend much time learning about as we went through our training. So it's really important also to recognize the patient who has the small box, that is the somewhat hypoplastic mandible and receding chin, and that excess submental volume. Those are patients that are going to need this kind of open neck, deep cervicoplasty approach. And I think, Jerry has so beautifully shown that it's really not just volume reduction, it's the fine tuning adjustments of the muscles, the digastric mylohyoid. Of course, they aren't worked on perhaps as much as the fat, but the hyoid fascia, I mean, you weigh that volume, it's not very much, but they can be powerful moves in terms of moving the anatomy in the direction of a more aesthetic contour. So as he's emphasized, it's a sculpting procedure. It's a lot like doing a breast reduction, where it's not so much what you take out, but is more important what's left behind. So I think also pay attention to moving the submental incision. If you're trying to do this through a submental crease incision, these structures are a long ways away, and it becomes more dangerous because it becomes your vision, your lighting, your exposure is not as good. So move the incision about a 1.5 centimeters caudal to the submental crease, closer to the hyoid. You'll find that it's much easier to do the procedure that way, and the scar is absolutely inconsequential. As I've done this more and more, there are a couple of things that I just wanted to mention. You will oftentimes encounter some large crossing veins as you're elevating the platysma. On top of the platysma or below it, there can be these large crossing veins that come through the fat. You need to control those with ligament clips. And if you see it on one side, it's very likely that you're going to encounter it on the other side as well. I like to use loops for this and a small lighted retractor. Take your time, particularly with the submental or submandibular glands. You need to have good suction ligament clips, the paddle cautery, and try to follow the natural cleavage planes in the gland. Tim Marten was just telling us about a course that he taught 20 years ago on this, and I think many of the principles still stand. There's almost always a lateral and caudal extension of the superficial lobe, which if you don't expose that and leave it behind, it'll almost always be palpable or visible. So I concur with Jerry's admonition to completely free up the superficial lobe so that you can really see which portions of it descend below that imaginary horizontal plane that you're trying to recreate. I had a couple of sialoseals early when I started doing this until I started using Botox. Jerry uses, I think, 8 units. I use 10, and then close the capsules. I don't use drains. I know Tim does, but it's important also to leave fat over and just below the hyoid as a pedicle fat flap that you can thin and reinset over the hyoid and hyoid fascia so as not to create too sharp an angle, which can look unnatural. Mario Sarabolo has talked about that V-neck, which can be anesthetic. I know Andrea Alversvalt really described this fat flap, and it's nice to preserve that. You can always take it out at the end if you don't need it. Jerry mentioned one significant hematoma in the paper. It was a supraplatysmal space hematoma prior to him beginning to use the Auerswald hemostatic net. I've become a big fan of using the net, as have many excellent surgeons around the world. It not only reduces the chances of having a hematoma to almost zero, but it helps redistribute and secure the skin to enhance the final aesthetic result. And even though it takes time to put it in, it can be done very artistically, and the skin vectored in different directions depending on where it needs to go. and really has been no consequence to the patients in terms of acceptance whatsoever. So I now use the Auerswald hemostatic net in almost every case. I'm going to hold off on posing questions to Jerry until Dr. Marten has had a chance to make his comments and we see what questions we get from our participating audience. But I want to leave you with just one thought. If you want to build a large facelift practice, study this paper, learn the technique of deep cervicoplasty, as well as excellent facial fat grafting, and you'll see results like you've never achieved before.
Thank you so much, Dr. Grotting. Really excellent, excellent advice. Laura, Jerry had mentioned that it looks like they capped us at 100 people. If there's any way to open it up to more, that would be wonderful. And in the meantime, we're going to turn it over to Dr. Tim Marten.
Thank you. This is an important paper. Jim, your last comment, often the results of our facelifts are judged by the outcome we achieve in the neck. I think for decades, we were hyper-focused on the facelift part of the facial rejuvenation, doing long, difficult SMAS operations and ignoring the neck. I agree, Jim, that if a young surgeon, if you want to build a facial rejuvenation practice, the key is to learn how to do a good neck lift. And this paper encapsulates so many important points. The first is that this is based on analysis, not magical thinking. And the traditional approach to the neck by plastic surgeons was a series of steps of magical thinking. You were told to do a certain thing and you executed that, and somehow it was supposed to work. And we were typically grinding away on the superficial layer, doing aggressive liposuction and tightening the skin and platysma and ignoring the deep layer. Jerry, your paper shifts a movement away from magical thinking to analysis. I often say that a neck is a big rhinoplasty. And for many years, rhinoplasty was a cookie cutter operation, a series of steps you executed. And if you had the right nose, you got a good result. But if you had the wrong nose, you got a bad result. And rhinoplasty surgeons got smart. Rather than just doing a cookie cutter operation, they said, we're going to look at the nose and try to decide preoperatively what's wrong with it. And then we're going to use and employ logical solutions to solve those problems. So, suddenly surgeons said, if the tip is poorly supported, we need a columellar strut or a tip graft. If the nasal bones are short, we're going to need spreader grafts. And the nasal surgeons went down this path of analyzing the nose and applying logical solutions, and rhinoplasty became more complicated, but it became a much better and more predictable operation. Unfortunately, face and neck lift surgeons haven't thought that way until recently. Neck lift was a cookie cutter procedure over-focused on the superficial layer. And what Jerry's telling you here is that the action is in the deep layer. And no more clear example of this exists than the short scar neck lift, where a neck lift is performed only through a submetal incision. There are no incisions around the ear. And the operation is focused on the deep neck, the subplatysmal neck. If you learn how to treat these subplatysmal structures, you don't even have to form a corset platysmoplasty. The platysma is just put back under natural tension. The skin is allowed to redistribute itself, and the results can be spectacular. And this shows the unimportance of skin removal, of corset platysmoplasty or lateral platysma suspension. The short scar neck lift shows us that those are not important. I think in your paper, Jerry, you made the point that most of the volume you were taking out was taken out of the deep neck. And this is important because, again, our traditional focus as plastic surgeons was grinding away on the superficial fat. And if you look at the young neck, the teenager, the college student, it's plushly padded and soft, and you can't see any of the underlying anatomy. If you look at most of our published facelift results, the neck is skeletonized. We've over-treated the subcutaneous fat. And I think I was at an aesthetic meeting with Jim Stews, and we typically would meet to discuss facial rejuvenation. And at one meeting, Jim said, Tim, I'm taking less fat out of the the superficial neck, and the results are looking better. And at that stage in my career, I took great pride in going in and cleaning out all the superficial fat and had a glistening platysma in front of me. And slowly but surely, I realized this was a mistake. I started taking out less and less fat. And now I advocate in most cases taking out almost none. So my typical approach now is to treat the deep neck first, see what I get, and then just polish that subcutaneous layer and try to leave as much fat as possible behind. The paper is so elegantly written that every sentence is important, but I think a reader can get lost at the overall importance. I think the key maneuvers are learning how to treat the subplatysmal fat and the submandibular gland. And the rest of these maneuvers are less important. And I think that the young surgeon learning this should try to master those two steps, or I often say the triad of reducing subplatysmal fat, reducing the gland, and then treating the digastric. Those are the key maneuvers. In fact, those are the maneuvers that I use in my everyday practice. A few comments were made. I went through a stage where I tried not to use drains for about 6 years, and I paid a price for it. I think the patients had more induration and hardness in the neck. It's not only salivary leakage, it's leakage of lymph fluid. When you reduce the subplatysmal fat, you're going through lymph nodes and you're going to have some lymphatic drainage that I don't think a net will completely control. And it took me a while to realize my patients were just having a harder time, and putting in a subplatysmal drain is such a simple solution that gives them a soft neck early on and pulls everything down. And I think that, this has served me well for 30 years. As far as Botox in the submandibular gland, I'd like to just put out a word of caution. Aside from this being an off-label use, there have been several reports of people ending up in the hospital on feeding tubes with dysphagia when surgeons have tried to do that. I don't think the surgeons who had the problem have published this result, but I'm aware of them. And I don't think this is necessary. It hasn't been necessary in my practice. I would caution young surgeons about trying to inject Botox into the submandibular gland. You're very close to the muscles that patients swallow and speak with. And it's really not necessary. A drain is a much safer solution. Same with trying to close the capsule or oversew the edge of the gland. These are risky maneuvers where in the process of trying to do that, you're more likely to tear a blood vessel or spear some adjacent structure. Just simply having a drain there to pull the platysma down on the cut edge of the gland is much simpler. And it is in fact how we treat other problem wounds. We put a muscle flap over a pressure sore or open wound. As far as Ligaclips go, those are convenient, but the problem with a Ligaclip is if you then push a sponge in the wound and pull that sponge out, a lot of times it will pop the Ligaclips off. So I would recommend cautery, and in the case of actual vessels, 4 out of 5 times I can identify the vessel within the gland, and rather than cauterize it, even ligate it. Those are my key comments. I think I should stop talking, and we should go to questions and answers.
Well, thank you, Dr. Marten. We all really appreciate your insight. I know Dr. Grotting had some questions. Why don't we go with those questions?
Well, are there any in the chat room that we should address first? I mean, I'm
sure. And I know Dr. Nahai wanted to make a comment as well. So if Dr. Nahai is available.
I want to make more than one comment. First of all, Jerry, congratulations. Your work is excellent. Your paper's beautiful and beautifully illustrated. And thank you for picking the right journal to publish it in. You've broken all records. I thought that we had upgraded our system so that we don't cut off at 100. So my regrets. I thought Phaedra had upgraded us, but it seems as if we didn't. So congratulations, you've broken all records. As editor, I have always refrained from writing commentaries on papers, and I used a lot of restraint this time, but I did choose to write an accompanying editorial that I mentioned My Way or the Highway, and I was even tempted to call it than a highway or the highway. And what prompted me to do that is that I have had some pushback from patients who have been told that if you touch the submandibular gland, you'll end up with a dry mouth, your teeth will drop out. And it takes me back to the days when I got interested in doing this from the work of Bruce Connell, my friendship and admiration of Tim Marten. And I remember the days, and I'm sure Tim will remember the days, where Baman Gairan, Tim Marten, and I, and correct me, Tim, if I'm mistaken, we're the only people advocating doing this, working deep to the platysma, and we were vilified one day. We will, that our patients are going to have dry mouth, they're going to end up with airway obstruction. So that, by way of background and why I chose to write that editorial. But the question I have, and it's for all three of you that have spoken, I've been fortunate that I've had none of the complications of dry mouth, hematoma, airway obstruction, radical neck appearance. I know that Andre's paper published in ASJ had none of those complications in 400 plus cases. You didn't. Personal communications with Tim and Jim, and you can correct me both. We've not seen any of those devastating or life-threatening complications. The only one I'm aware of is the paper that Brian Mendelsohn published in PRS with a basically life-threatening hematoma in his recovery room, and he was able to save the patient's life. So kudos and congratulations to you, Jerry. Beautiful paper. And for you and the discussants, a few words about safety in your hands and about recommending this. And I think, Jim, you recommended this to upgrade one's facial aesthetic surgery practice. But a word about, how much experience do we need? You and I, all three of us grew up in the days where as general surgeons, we did a lot of facial extirpative surgery. We know the anatomy of that area. So all three of you, please comment about safety in your hands. And the advice you would give is, if Fuad has just finished his aesthetic residency and wanted to do this, what would be your advice?
Well, I'll start it off. As a young surgeon, the first thing you want to do is learn the anatomy. And I would say, I'm a disciple of Bob Ackland, who I know Dr. Nahai was very close with from Europe. And he force-fed us anatomy at a very young age. And so that is that's an advantage that's probably not fair for everyone else. But after you get a good understanding of the anatomy, you want to prepare for the operation like you would anything else. You need to have the proper instrumentation. It needs to be available in the room before you start the operation. These are longer instruments so that you can reach into the areas. You need to have a lighted retractor. You need to have something to evacuate the smoke from the area that you're operating in. And you need to have assistants that understand that you're doing something significant and it's time to pay attention to what you're doing. Once you start the operation, moving the incision posterior to the submental crease, which has been still preached by a lot of people, gives you a significant advantage. Andre Arsvald will go as close as 1 centimeter anterior to the hyoid. I know that Tim, he's got a great math equation. The parabolic impact of opening an incision, moving it just a little bit longer gives you a much larger diameter and access. And then exposure is critical. The platysma needs to be elevated, and you need to be able to see under the platysma from the cricoid to the menton, identifying the gland in a big pocket, not looking to a tunnel. And then the capsule can be incised safely along the inferior edge all the way to the facial vein, which gives you even better access. And then finally, mobilization. And so when you're taking the gland out, which is really the thing that scares everybody, I'm like Tim, I like the discipline of finding the perforators. There's going to be at least one and sometimes as many as 3 or 4. And if you're going slow enough that you're looking for the perforators, you should be able to control them. When I use a ligament clip, I use the ligament clip only as a point before I coagulate it. I ligament clip and then coagulate across it. But that discipline of looking for the vessels puts you in a position where you're ready to go. And then when the bleeding starts, when you get bleeding, I've found one trick that I learned from Lucian Ion is a suction cautery that the ENT doctors use. It can sometimes be very helpful. I keep it in the room. I never open it, but it stays there as a good luck charm unless I need it. Those are the steps that I would take as first starting. The first operation, I wouldn't take anything. I would just give the exposure and look at all of the various elements. And don't do things you're not comfortable doing, and follow the basic principle of surgery. Don't work in holes where you cannot see.
I think those are really, really excellent comments. I spent a good bit of time just trying to understand the anatomy and trying to understand exactly what I was supposed to be seeing and trying to accomplish, working with Jerry, working with Andre, working with Ozan, working with Tim. And just, once you understand the anatomy, it's a sculpting procedure, and you have to understand what is the end result that you're trying to achieve. If you're going to start shaving off the digastric, well, how much do you take? When do you stop? And you have to understand that angle or that plane that you're going for. And if you don't understand the end point, then it's best not to even get started. But you can stick your toe in the water here. Everybody knows how to make a submental incision. Everybody knows how to find the platysma. You can elevate the platysma. You can look at the subplatysmal fat, but just don't take too much of it if you're not going to deal with the gland. Because then you will end up with that cobra deformity, which is almost impossible to fix. But the other thing is, I think all of us I have an open operating room. If somebody wants to come and watch me do one of these operations, please get in touch with me and we can work it out. There's so many good teaching videos, and now with Jerry's paper, Andre's paper, Tim has so much good teaching material, Fuad. It's pretty easy to find videos that really can show you almost better what you're trying to achieve, what you're looking for, than looking over a surgeon's shoulder in the operating room. It's a very small little hole. Sometimes you can't see very much. But Tim talked about it being a big rhinoplasty, which I agree with. I think of it more as being the equivalent of microsurgery in facial rejuvenation. I've got my loops on. I'm looking at tiny vessels. I'm looking at lymph nodes. I'm moving critical structures out of the way. If I want to be able to see that facial vein that kind of marks the lateral limit of the dissection around the submandibular gland. I never want to see the hypoglossal nerve. That's below the deep lobe of the submandibular gland. If you're there, you're way away from where you should be. There are cervical branches that you need to preserve. There is a significant incidence of lower lip dysfunction after this. Generally, it resolves after a week or two. Sometimes it goes longer than that, but those are usually traction injuries. They're typically not due to a marginal mandibular branch injury. Sometimes the cervical branches can get tweaked. Sometimes the platysma is more of an important component of how the lower lip moves. So all of these kind of things you develop a feel for and conscientiousness for what you're trying to achieve over time. And with experience, it becomes a very rewarding operation. It still takes me a good hour to do this at the beginning of the case. A fat neck, it may take more than that. A skinny neck, I can do it a little faster. Sometimes patients have no bleeding whatsoever. Also, the use of Exparel, sometimes some steroid in the digastric and in the platysma, I think is helpful, because sometimes these patients have a little more discomfort from what we do. So it's, you know, it's a significant operation, but very, very rewarding. Best results in the neck I've ever seen.
Very nice. So we just sent out our polls, and our poll questions are kind of more geared towards what people's practices in terms of deep plane cervicalplasty and what their hesitation is. I just started practice. I love doing face and neck lifts. And this paper is, like Dr. Nahai said, the most beautiful, well-written, intimidating, but very, very helpful paper. So we asked our audience, do you routinely open the central neck for your neck lifts? 77% of our audience said yes. 8% of our audience said sometimes they perform a lateral approach only, and 15% of our audience said that they rarely or never open the central neck. Our second question, do you perform deep plane cervicalplasty for your neck lifts? 30% say always, 30% say sometimes, 20% say rarely, and 21% of our audience never ever performs a deep plane cervicalplasty. And finally, if you have hesitated to perform deep plane cervicalplasty, what is the reason? 47% of our audience has the potential complications. 15% has difficulty with visualization. 6% finds the anatomy difficult. 23% has never performed it before and doesn't know where to start. And approximately 9% of our audience feels that they obtain adequate neck contouring without entering the deep plane. So food for thought there. I think this paper really helps elucidate a lot of the reasons why it's a great procedure and how to get started, perhaps. In the chat box, a question from Alexander Anzarut. I hope I pronounced that correctly. He mentioned that there are therapies like Morpheus and other radiofrequency therapies for the neck. They're around more commonly. People are getting them as kind of a stepping stone to facelift neck lift. How does this change your approach? And is there a minimal wait time before you'll perform a neck lift for someone who's had a therapy like this?
Jerry,
You're muted, Jerry.
Dr. Daniel.
Tim, you want to take that? You have a strong opinion about that.
I do. I know I think you're in alignment with me. So this is conceptually flawed. Liposuction, anything that treats the superficial fat, radiofrequency, ultrasound, Kybella, is treating the wrong layer. If there's one overriding message from Dr. Daniel's paper, is that the problem is under the platysma, not in front of it. And that superficial fat is key to a youthful appearance. We don't want to beat on it. We don't want to scrape it all out. And unfortunately, we're starting to see a number of neck cripples from over treatment with non-invasive therapy. People with no subcutaneous fat and heavily scarred platysmas. And this is going to be a problem for us. I don't know when the exact interval to reoperate, but I generally try to make people with those stiff beat up necks wait a year before I try to get back in there, because you're often, peeling skin off of platysma. Jerry, what would be your additions or comments on that?
Well, and I mentioned that in the paper. A third of my patients had previous surgeries, and some were liposuction with facelifts, but a lot of them were devices and chemical lipolyses. And I'll take a liposuction any day, because you leave a little bit of fat behind. But these indiscriminate destroyers of tissue not only destroy the fat, but they're also burning the platysma and the skin. And so I see cicatrix for the skin is stuck to platysma. Platysma is unidentifiable. And so I think the person operating has to be aware you've got to treat that very delicately. You could lose skin, theoretically, raising your skin flaps. And then when it's done, you need to tell the patient preoperatively, you're going to have irregularities that I possibly cannot cover. You're going to have indentations and irregularities in your neck that could be permanent unless we go back and do fat grafting at a second setting. I've not done fat grafting at the first setting, though I know it's been advocated by some people before you do a neck lift. So I don't know if you have any thoughts on that, if you guys do.
I do. Sometimes putting fat back is a better solution than trying to do a neck lift, just to get rid of the cadaver-like look, to soften the neck, even if it does have some platysmal problems.
Another question from Denis Berger. I think he is available to ask this question himself, Dr. Berger. I hope I pronounced it correctly.
Yes, just a second, please. I'd like to ask the speaker how they evaluate the submandibular gland endpoint resection, because you operate on Trendelenburg position for better visualization, and the anatomy gets very different from the patient standing up position. Thank you.
Thank you, Deniz. The line you're looking for is going, this was taught to me by Tim and Andre, is looking at the mandibular border to the greater cornu of the hyoid. And you really, as Jim pointed out, you've got to take the most lateral aspect as well. So the anterior component is fairly easy to get to. It's the posterior that's more difficult. I think number one, you have to look at your anesthetic type. If you're using an LMA, that can give you a little more pressure on the floor of the mouth as well as the hypopharynx and push the submandibular gland in a more inferior position, which might assist in taking it out. I don't use an LMA. I use IV sedation, and I feel that that there's no distortion. Now, true, it's in a Trendelenburg position. However, in my patients, which is confirmed for the cadaver dissections, the gland is always very tightly held within the pocket by the capsule. So when I'm mobilizing it, it's not like I'm bringing extra gland down, and it certainly is not going superiorly. So I feel confident that I'm looking at it in a supine position is the same as an upright once it's mobilized. And the bigger mistake that I make, as Jim pointed out earlier, is getting that most posterior lateral aspect of the gland, taking that, because I've done the whole operation, they come back and there's the nubbing sitting there, and I should have taken a little bit more, and I just missed the plane. So I think that is the bigger concern. Because it really is stuck in there. People talk about ptosis of the gland, and I'm sure I've seen it. I've seen it after I've mobilized the gland where it's fallen after surgery, but I think it's socked in with the tendons, and the position of the patient doesn't really change it, but anesthetic might.
May I comment? This is an important question, because no amount of surgical technique is useful without some kind of aesthetic endpoint. So understanding what you're trying to do, it's not enough just to take a chunk out of the gland. You have to sculpt the gland to create the contour you're looking at. And the best way I've been able to help people visualize this is that the ideal neckline would be a clean plane from the mandibular border to the ipsilateral digastric to the contralateral digastric to the contralateral mandibular border. Between the two digastrics, the problem is the subplatysmal fat, and between the digastric and the mandibular border, the problem is the submandibular gland. So when you're removing the gland, you're imagining a plane tangent to the mandibular border and the ipsilateral digastric, just like when you're doing a rhinoplasty and you put your chisel in, you're looking at a straight line from the tip to the radix. And once you conceptualize that is what you try to execute in surgery. I don't think the gland moves. I agree with Jerry that it's fixed. If you recall your anatomy, the submandibular gland is split into a superficial and deep lobe by the mylohyoid, which essentially fixes it in position. So the whole idea of the submandibular gland being ptotic is a fallacy that has led us to futile attempts to raise the gland by tightening the platysma, something that surgeons who do a lot of neck work know doesn't work. The gland is big, and trying to lift it is like trying to put 2 liters of water in a 1 liter bottle. There's just not enough room for it. This also gets to Foad's question about dry mouth. The ENT surgeons know from doing surgery for tumors that you can often remove 1 or 2 submandibular glands in a good part of the parotid, and people often won't get dry mouth. The submandibular glands are accessory to the parotid, which are the major glands, and the parotid secretion is more mucus rich than the submandibular gland secretions. but also the superficial lobe of the submandibular gland comprises less than half of the gland. The majority of the gland is up in the floor of the mouth above the mylohyoid. And we're taking out part of the superficial lobe. And I think it was in 2014, I reviewed 1,034 cases and we had no dry mouth. So I think this is not a reason to not do the surgery. There are patients who will temporarily have a little postprandial pain and some temporary sublingual dryness, but no patient I know has had permanent dry mouth from submandibular gland reduction.
I'd like to make one comment too, on Botox in the gland. I think there's the difference between trying to inject Botox into a gland percutaneously that you're trying to feel with an 1.5 inch, 25 gauge needle or something like that. When you're in there and you have just cut across the gland and you're looking at it with loops, you've got a 1 cc syringe, 10 units of Botox, 30 gauge needle. You cannot miss the gland. If you squirt it into the mylohyoid or the tongue or something like that, you shouldn't be doing the operation. But it's a very carefully controlled procedure that I think has been very helpful in preventing sialocele. Jerry, what are your thoughts about that?
I'd used it for a long time, and then I tried to stop using it. And I was with Andre Arsvald. We were trying to adopt his net, suturing the gland together just to reposition it and try new things. And I had probably the majority of those sialoceles happened within about I think they all happened within about a 3-month period. And now I don't put drains in the deep pocket. I use the hemostatic net. Now, since I've gone back to the using the neuromodulator and using the net, and that would have been in December 2018. And I do, on average, nearly 100 of these a year, and I have not had a sialocele since then. So I still use it, and I like it. I know that Andre still uses it as well. Ozan uses it.
I just want to make the point that this is off-label use. And the 2 cases I know, Jim, are both intraoperative Botox injections by experienced surgeons. So they were injecting the Botox as you described, and patients ended up in the hospital with feeding tubes. So
well, I think it's a very important point, but it falls into the same category as the Brian Mendelsohn bleed. Fortunately, it's a reportable event, but extremely rare. And I don't think, I wouldn't stop doing a submandibular gland resection because of one case report.
No, and the other question, is it necessary?
Yeah.
I've done this for 30 years without putting Botox in the gland. And I think we've had 6 sialoceles, and those were all in the phase where I wasn't putting a drain in. So just counterpoint.
Yeah.
We say these things on these panels, and young surgeons pick these ideas up, and I'm just saying, be careful, please.
Fair point.
Point well taken.
A quick question in the chat box about a tuxter suture. What is your opinion about the tuxter suture? I'm not familiar with it myself, but.
The tuxter suture was described by Joe Feldman, and he used it from the midline. He used a proline suture and used it to run through the superficial cervical fascia from the midline to the mastoid fascia. And he also had a suture he called the Go Anywhere suture, which was very similar. And he used that just to envelop the superficial cervical fascia to create a very smooth layer. One of the things I think that Tim just pointed out is the fact that Dr. Feldman cleaned the platysma off all the way down to the superficial cervical fascia. If you're leaving the fat there, there's probably less, there's less of an indication. Now, I do use a barb suture that I like just for the contouring, and because I close the platysma, it's a longer suture. It was described by Ozan Sozar, and it's a barb suture. There's no tension on it, unlike the tuxter suture. And you can find the reference on that in Dr. Feldman's book, Necklift, which is a very, very good book.
if I can comment, I think the idea of a Tuxter suture, unfortunately, it's getting back to the idea that the gland is ptotic and you can push it back up into the floor of the mouth by tightening the platysma. And I want to tell people that that's the mistake we've made for the last 3 decades, thinking that the gland is ptotic and we can push it back up into position. The gland is big, not ptotic. And you can't put 2 liters of water in a 1 liter bottle. You can't push it back up. Some surgeons have even tried putting a mattress suture through the floor of the mouth under the tongue to pull the submandibular gland up into the floor of the mouth. And believe me, they had problems. This didn't work. A much simpler solution and a more rational one based in the anatomy is when the gland is large, you reduce it in size. So I want people watching this to think more about taking out excess volume rather than trying to force contour by tightening the platysma. This is a mistake that's been made in the past, and I would like young surgeons to not have to make that same mistake. Something else that was mentioned about diagnosing the problem, often surgeons just treating the superficial neck will only show a lateral photograph, and sometimes that will give a decent lateral photo or even just taking out subplatysmal fat. But when the patient looks down, the large submandibular glands will herniate forward. So the simple test as to whether you need to do the work in the deep neck and do the things Jerry outlined in his paper is to take a picture of the patient looking down. And if the neck is full, that is a subplatysmal, not a supraplatysmal problem. If the patient looks down and their neck is full, you've got some deep layer problems that you have to treat. And it's not just subplatysmal fat, it's the submandibular gland as well. So I encourage all surgeons to take a looking down view. I compliment Jerry in your paper, you published the looking down Cannell's view, because this is an important diagnostic feature. Again, it's like rhinoplasty. They demanded 4 views of the nose and you were laughed off stage if you tried to present a nose and didn't show it in 4 views, whereas we see often in face and neck lift lectures, just seeing 1 view of the neck. And the neck is a 3-dimensional structure. We have to look at more than 1 view.
Dr. Auerswald is in the audience and he has a question.
Can you hear me?
Yes.
Yes.
Sir.
Oh, thank you. Good to be with you. Thanks so much to allow me to ask this question to this great surgeons, Tim Marten, who inspired me to do the deep neck surgery. I have been following him for many, many years. And then I met Jim, Jerry, Dr. Fuad, and thanks so much to be here with you. I would like to ask you, what do you do to the low set hyoid? I mean, Timothy Marten emphasized that it's impossible to put 1 liter of water, 2 liters of water in 1 liter bottle. And I think this is related to the size of the tongue. And larger tongues push the gland down. So if you try to push back the gland upward towards the base of the tongue, it's possibly almost impossible. We see recurrence very frequently. So this increased size of the tongue also pushes the hyoid inferiorly, displaces inferiorly because of this enlarged volume in the mandible confines. What would you do to do you do to elevate the hyoid in patients that have this low set hyoid? I would like to ask Dr. Fuad. I know that has a very large experience as well. So to all the panelists and including Dr. Fuad.
I would prefer not to take up everybody's time. I'm happy to make comments, but I will defer to the others, Andre. It's so good to hear your comments, and we're all very well aware and grateful for all your contributions. I'm just here as the editor of the journal, so I'll let the discussant carry on with the discussion.
Okay, thanks. I understand. Thanks so much.
Jerry, you make a number of points in your paper about how to reposition the hyoid with myelohyoid, either resection or detaching it from the hyoid, and also hyoid fascia. I really haven't seen enlarged myelohyoid. At least I haven't recognized an enlarged myelohyoid. And it's a very good question that Andre asks. And I think that's something that I remain a little bit confused about. I certainly do the digastric plication. That is, I think, is the most effective way. Daniel Labbé introduced that, and I do that. And for me, that's been the best way to elevate it. And if it's stuck, I do release the fascia. But beyond that, I think you're the expert here. I know Tim has experience here as well.
Well, in the paper, very seldom did we take the myelohyoid out. So the first and foremost, the hyoid position can be seen in thin people. It can be seen in heavy people. It's that, and you have to differentiate between the two with the hyoid position inferiorly. The patient that has a hyoid malposition is diagnosed by the anesthesia provider. They walk in the room, and when you see them get the difficult intubation tray out, you know that person's hyoid is going to be anteriorly displaced and inferiorly displaced. So you'll know something has to be done. In the way I got to the digastric or the myelohyoid, we'll start there, trimming that, we're in these really dense, heavy necks with the Malin-Pot number 4, size 4 tongues. As Andre was talking about, this huge volume that you're trying to elevate. And when I would reflect the fat, I would find that in those heavy necks, the myelohyoid actually extends caudally below the anterior bellies of the digastric muscle. So before I pulled the muscle together, it was my idea to try to reduce that volume, because the myelohyoid is expendable in the midline. It's a very thin muscle before you get to the genioglossus, and it's safe. So I began to reduce that in an effort to once again reduce the volume before I would pull the digastric muscles together. I started releasing in thin patients where the myelohyoid was cephalad to the anterior digastric muscles, but I was trying to reposition the hyoid. I found that sometimes when I would pull the tendons together, I didn't feel like it was moving, the hyoid was moving very well. So I took this next step to release the myelohyoid attachments to the hyoid bone, and I felt like I was getting better elevation of the hyoid into a better position, particularly in those short necks where the distance is 2 centimeters from the menton to the hyoid. Now that differentiates from the digastric plication that Daniel Labbé talks about, where you're lifting the myelohyoid by pulling the not at the pulleys, but more the central body. And I did that for a while. I don't do that as often anymore. I would prefer to reduce them and then put the fat back. But certainly for repositioning the hyoid, it's got to be tendinous by just medial to the pulleys on both sides. And I use an absorbable suture, and I've not had issues where I've seen sculpting where the glands pull, or the muscle pulleys pull apart to date.
Dr. Marten, do you mind giving us your thoughts on the hyoid?
I'd like to give some counterpoint. So this paper covers a lot of esoteric territory, and I don't want people to get lost. I think we always have to pick our battles, and it's not necessary to do everything described in this paper for a young surgeon to be successful. So I think, Jerry, you would agree the key maneuvers here are reducing the subplatysmal fat and the submandibular gland. And to my mind, 95% of the improvement comes from those 2 maneuvers once you master those. And then the third most important maneuver in my mind is the digastric reduction. I leave the interdigastric fat between the digastrics, and I think that's important. And when you're done reducing the subplatysmal fat in the submandibular gland, you'll see a little fullness of the digastric in some patients. by the hyoid, the so-called low hyoid, and taking out a small amount of muscle there will increase the cervical mental angle. But my feeling is that the hyoid is fixed in many ways, and we're not able to manipulate it in the way that we think. The suturing of the digastric bellies, having been around now for 30 years, this has been tried and failed in the past, and I'm a little concerned that it's being revisited again. Typically, the problem is you'd suture the muscles together, and then they eventually pull apart, and the patients have too much submental hollowness. I also think that there's some concerns about tight suturing of the pulleys in voice professionals. I usually don't shave the digastrics in a pop singer, an opera singer, or some voice professional. I'll just reduce the subplatysmal fat and the submandibular gland. And when you start talking about suturing deeper structures, resecting myohyaloid, suturing strap muscles, I think the return on those maneuvers for the amount of risk that you incur is not favorable for the beginning surgeon. So I would say that while all these things are ingenious ways of trying to improve the neck, I've gotten by with just the triad of subplatysmal fat reduction, submandibular gland reduction, leaving the interdigastric fat, and just resecting a partial myectomy of the digastric near the hyoid. And I published my results, and I think they're as good as any I've seen where surgeons have gone beyond that. So I would say those are the key maneuvers, and these other maneuvers may add something to that, but the addition gained is possibly not worth the risk that a young surgeon would take trying to do it.
I would absolutely agree with you, Tim. And if you look at that's the reason I put frequency in there, because these are not frequently performed maneuvers, and those patients are selected as outliers. And I agree completely with you on the triad.
Jerry, how frequently do you reduce submandibular gland and subplatysmal fat? Frequently, I assume.
Correct.
In the majority of my neck lifts, I do. People think that it's an unusual maneuver, but those are the key maneuvers that I think one has to master if they want a good neck. Let me ask you another question. Do you think it's really possible to do a good neck lift without a submental incision? I know this debate goes on, but all the maneuvers you described, in my mind, can't be done from a lateral approach. You can wedge out a little piece of submandibular gland from the lateral approach, but you can't actually sculpt it. You can't sculpt the subplatysmal fat or modify the digastric unless you have that inch-long submental incision. So I feel that people will make 3 inches of incisions around the ear, and they're afraid to make a 1-inch incision under the chin when the payoff is so high. Having access to the deep neck from an anterior approach is just so important. I can't do what I do without that incision. What's your opinion on that?
I went through a phase, and this paper was part of it, where I was trying not to open the neck because everybody was trying to do it from a lateral aspect. And I found myself opening the neck after I tried everything lateral because the digastric muscle was visible. I even tried liposuctioning the deep fat because Mario convinced me to try it. I'm back to it's too firm, and you can't control it. And because I've seen such huge vessels running in that space, the idea of hitting one of those large communicating veins is not on my plate of things I wanted to do. So I shifted over. This paper was 70-30 essentially open versus lateral. I'm probably back at 85% opening the neck. And the only time I don't open the neck is when I have digastric or platysmal bands that are separated, and I have a large jaw with a very obvious deficient or empty deep neck.
For historical perspective, that when they would take submandibular gland tumors out, the otolaryngologists, they used a lateral approach, and it was always a fearful, complicated operation that everyone sweated over. And then these surgeons, when they came, watched me reduce the submandibular gland through a submental approach for aesthetic purposes. They were amazed. They said, for us, it was so complicated because we were plowing through all that lateral anatomy, vessels, the marginal mandibular branch, the cervical branch. where between the submental incision and that gland, there are no significant neurovascular structures. It's a straight, safe path. So I was confounded when surgeons started proposing a lateral approach to the deep neck, because you're plowing through all that anatomy. So I would urge young surgeons to think about which approach is safer before they, choose.
Sure. I would absolutely concur with that. I've never regretted opening the neck. I've regretted not opening the neck. And, the lip lift operation is all the rage these days and can give amazing results, but you're making an incision that's pretty visible. True, it heals up great, but it's right there in the central face. And yet, we still argue about whether or not an incision, that every kid who ever learned how to ride a bicycle basically has a scar in that location. Anyway, so.
Well said.
We have 2 questions directed to Dr. Marten regarding his subplatysmal drains. One, is it placed from lateral to medial under the entire platysma through the posterior neck hairline? And 2, how long do you keep them in?
Good question. The way I was taught to do it, the way I still do it, is the drain is placed post-auricularly in the post-auricular scalp, and it traverses subcutaneously for a short path. Basically, I push it out the submental incision, and then I come in from the submental incision with a mixture right angle clamp. After I've done all my work, including the platysmoplasty, I go down to my bottom platysmoplasty suture, and I put the mixture clamp under the platysma and the tips where the submandibular gland is, and then I pop into the subcutaneous space with the tip of the instrument. My assistant feeds me the tip of the drain, and I pull it through, and now I've got the drain under one muscle. And then I take that right angle mixture working through the submental incision. I use it as a little hook to lift up the edge of the muscle on the other side, and I push the end of the drain across under the platysma to the opposite side where the submandibular gland is. So the drain is subcutaneous for a couple centimeters, and then it's under the platysma the rest of the way. And the reason I do it that way is Bruce Cannell told me, if you put the drain in first and then do your platysmoplasty, there's a good chance it's going to get caught in one of your platysmoplasty sutures and you're not going to be able to take it out. So it's much safer to do all your deep layer maneuvers, do your platysmoplasty, all your other maneuvers, and then put the drain in it in the way that I described, after those are done. And then we leave it in 5 days now. We used to take it out in a day or two, sort of the old general surgery rule when the drainage fell below 30 cc's in 8 hours. But sometimes the next morning, the drainage had gone to 0. We would pull the drain out, and then the patient would sit up, start moving their face, eating, chewing, stimulating their salivary glands, and there would be a second wave of lymph drainage from removal of the subplatysmal fat and leakage from the submandibular glands when people are eating. And then I started leaving them a little longer, 3 days. And then Val Ambrose told me, Tim, I'm leaving the drains in a little longer and the necks look really great. And he was right, as Val is about many things. We started leaving the drains until the first suture removal visit at 5 days. And this was a big step forward in getting a faster recovery. The patients have a much softer neck with less induration.
Thank you. Are there any other questions or comments from the speakers or the audience before we wrap?
Maybe I'll add just a few comments. You were talking about safety and how the operation is performed. A couple things. I think Jerry mentioned about having proper equipment. Also, focus of your OR team. I think you need to be scrubbed with 2 people. You can't just be scrubbed with one person. You need you're working through a small hole, and you need one person just to give you exposure and another person have instruments ready for you in case you encounter a problem or bleeding. And then I think you have, even though bleeding is rare, if you control the operation, you have to have an algorithm for managing that problem. So the key step is to overmobilize the gland so you have surgical control of it. It's not like you just expose the part you want to take off and then saw that off. You need to expose more of the gland than you're going to take out. And a helpful maneuver is when you hit bleeding, pull down on the gland inferiorly, and that will slow it down or even stop it. And your first maneuver, if you get bleeding, is to just try to cauterize it with paddle cautery. And the key is it's going to bleed from both the patient side and the specimen side of the gland. So you have to move your cautery instrument back and forth to catch both sides. If that doesn't work, the next step is to pull the gland down, have your assistant give you insulated forceps, and try to grab the bleeding point with the insulated forceps, and then suction out the cavity and have your assistant apply cautery to that forceps. The third step is, if that doesn't work, you pull down on the gland and you take your insulated forceps and you compress the entire cut edge of the gland. Pull it down, put the forceps across the cut edge of the gland, compress the whole edge of the gland. That will stop the bleeding, irrigate out the cavity, suction it out, and then slowly release it and find the bleeding point. And then the fourth step is, if that doesn't work, put a sponge on your finger, put your finger in the cavity and press the gland up against the mandibular border and hold it tightly for 5 minutes. It's sort of like when you take the aortic balloon pump out of the femoral artery, you have the medical student hold pressure on that big hole in the femoral artery for 5 minutes and there's no bleeding. And you could take it as far as trauma surgeon. If you have bleeding that you still can't control, you could put your finger in the patient's mouth and compress the gland against the floor of the mouth with your finger in the floor of the mouth. So it's the same as doing hepatic surgery or splenic surgery or thyroid surgery. The surgeon has to have a plan. So I encourage you all, when you try this, to have that algorithm in your mind. Think through what you're going to do if you do encounter a problem, and you'll be fine.
Good points.
Thank you so much, Dr. Marten. Anyone else?
Mark, I want to thank the journal for the opportunity and for the ability to put my paper into your journal. I really appreciate the evening with these giants of plastic surgery. I've learned a lot, even once again. Thank you, guys.
Very an important and well-written paper. I commend you for a beautiful work. Thank you. It's important work. Thank you very much for what you did.
Thank you.
Well, I'd like to end by thanking Drs. Marten, Grotting, and O'Daniel for an absolutely phenomenal, I mean, it's an understatement how phenomenal this discussion was. So thank you. And thank you to Laura Simpson, Phaedra Kress for all the work in making tonight a success. We'll see you back here in September for the ASJ Next Gen Editors Journal Club, which is hosted by Ryan Austin. Have a great night, everyone, and thank you again.
Thanks to all.
Thank you.
Bye, everybody.
Enjoy the mountains, Jim.
Thank you.
See you, Tim. Mark, thanks for everything.